A very warm good evening to one and all. Welcome back to today's session. Today's our guest speaker name is Dr. R K BISWAS sir. So today's topic will be of COPD and its homeopathy management. And over to you, Pia Galani, for the further procedure. Yes.
Okay. So, very good evening to everyone present over there. We are here for a webinar on COPD. Welcome, Dr. Biswas, Dr. R K Biswas, sir. So, today I'll give a brief intro about HESIA. HESIA is All India Homeopathic Students and Youth Association, Empowering Homeopathy's Future. It was founded on October 31st, 2009. Its mission is dedicated to promoting homeopathy, fostering unity among students and professionals, and advancing homeopathic education and research. Its vision is to unite, power, and empower to shape the future of healthcare. Its objectives are to unify homeopathic students and nation worldwide, practice to promote sharing, collaboration, growth, support and empower homeopathic professionals, organize impactful conferences, seminars, workshops, and training programs. Its key initiatives are national and international conferences, seminars and workshops, homeopathic awareness programs and community outreach, training and certification programs for students and professionals. Its publications are newsletters, journals, and research papers, strategic collaborations with homeopathic organizations and institutions. It gives membership to homeopathic students, UG, PG, and PhD scholars, young homeopathic professionals, and homeopathic institutions and colleges. It is governed by national governing body, state committees, and local units. Its signature events are International Irish Conference, National Homeopathic Conferences, state-level seminars and workshops, webinars and online training programs. So let's join HESIA, connect with India's largest network of homeopathic students and professionals. Together, let's shape the future of homeopathy. Thank you. Over to Dr. Lavanya.
Thank you, Priya. Thank you. Thank you so much, Priya. And over to you, Dr. Monali. Yeah.
Am I audible?
Yes. Yeah.
Thank you. Today, I would like to introduce our today's guest speaker, Professor Dr. Rinku Biswas, Department of Pathology and Microbiology, Sri Ganganagar Homeopathic Medical College and Homeopathic Research Institute. That's in Tantia University of Rajasthan. He has also done his MSc in microbiology and MD in homeopathy. He is a consulting homeopathic physician for 18 plus years. He is also a guide and supervisor, PhD Homeopathy, Tantia University. Regarding his contribution and work done in the medical field, he worked and wrote and made first ever homeopathic anthem in history of homeopathy. Also sang and upload in YouTube channel, and it is also popular. This homeopathy anthem is listed and entered in World Record of India 2019 and also entered in Marvelous Records Book of India 2019, published in December 2019. Also, this work won more than 100 awards in medical health and academic field. He is also a president of HALPS Association, Homeopathic Association of Public Service in Rajasthan, and Kalyan Samiti at the Sri Ganganagar Hanumangarh branch. Not only this, he has also given free treatment and medicine to poor patients, widow ladies, physically challenged persons, and soldiers at his own clinics. Every year, approximately 25 to 30 free homeopathic medical camps are arranged and organized under his supervision by him and his team in different peripheral areas, schools, colleges, for awareness of homeopathy and benefit of patients. Every year, he distributes preventive and curative medicine for seasonal diseases like dengue, chikungunya, malaria, swine flu, etc., door to door, and by arranging camps in different areas or schools. During COVID-19 outbreak, he distributed free homeopathic immunity boosters in public, school, office, banks, health workers, corona warriors, and he has also been an active participant in Corona Warriors. He worked in COVID-19 and quarantine centers during COVID pandemic. Free distribution of masks, sanitizers, and food during COVID-19 pandemic, also during the lockdown. Not only this, he is an active social worker and social activist, an active blood donor
मैंने
in
only नहीं किया
every
था
3 months, which has been arranged by him donation camp from the needed people and the patient. Also arranged many clothes and sanitary, that's the stationary donation camps for poor people and children. Not only this, there are still many more works which he has been done. Also, he soon there is 2 books which is going to be published. First is The Magic of Mother Tincture and Homeopathic Therapeutic, and second book name is Har Dil Mein Kavi Hai. That's the Hindi poetry. More than 200 journals and articles in SCPUS, PubMeds, UGC, Care Indexed journals, example on the topic of renal calculi, hypertension, diabetes mellitus, asthma, hemorrhoid, suicidal tendency, obesity, dengue, etc., published in various international and national journals, magazines, and newspapers, etc. And he is still going on with the similar dedication with lots of motivation to all of us. I'm so much obliged to introduce you today, sir. We would love to hear from you. The stage is all yours. So, can you
Sir,
hear me?
Hello?
yes. Sir, can we have the PP2 to share, sir?
Yes,
Sir,
ma'am.
purpose.
Yes, so share the PPTs.
Sir, kindly give me a minute, sir.
Okay, ma'am.
Yes, sir. Your PPT is visible.
Yes, it is visible.
Yes, sir.
Oh.
It is visible. Thank you.
Very good evening to all of you. I'm thankful to ISAIA, All India Youth and Student Association to give me opportunity to give this live webinar and make the part of this live webinar series. And I welcome and my good evening to the all participants join this webinar. Today my topic is chronic obstructive pulmonary disease, COPD. Next slide, please. Next slide, please. COPD, chronic obstructive pulmonary disease, it is a group of pathological condition in which there is complete or partial obstruction of the airway at any level from the trachea. Please change the slide. Obstruction of the airway at any level from the trachea to the... Don't change the slide, ma'am. Obstruction to the airway and any level from the trachea to the smallest airway, resulting in the functional disability of the lungs. Please change the slide. So COPD is a group of disorder in which it make the breathe difficult. It is maybe a fresh condition or maybe a chronic condition which get worse over the time. Chronic obstructive pulmonary disease is a progressive disease which make it hard to breathe. It is progressive. It means day by day the condition become more worse over the time. Next slide, please. This is a structure of normal echinus, normal air cell, pre-terminal bronchiole, terminal bronchiole, respiratory bronchiole, alveolar duct, and there is so many alveolar sacs, which is formed by the alveolus. This is the chief air cell or primary air cell of the lungs. There is some amount of residual air always remaining in these lungs, and in the condition of COPD, there is holding capacity of the air is reduced. Also, there is excessive mucus secretion with difficulty in the breathing. Next slide, please. In the case of COPD, there is less air flows in and out of the airways because of one or more following the causes. The airway and the air sacs loses their elastic qualities because this air cells holding the airs, and at the time of expiration it inflamed by the air, and this activity elastic quality it is improved by the alpha-1 antitrypsin. In such cases or many cases of the COPD, the elasticity become lost due to alpha-1 antitrypsin deficiency. The walls become, many of the air sacs are destroyed. The causes of the destruction of this the air wall is loss of antitrypsin and the protein bands, or due to less amount of the alpha-1 antitrypsin, the proteolytic action become more effective or more prominent, and this elasticity become lost. The wall become, many of the air sacs are destroyed, or air space become dilated, or air holding capacity become reduced. The wall of the airway between thick and inflamed. The airway make more mucus than an usual because there is excessive excitatory action of the mucus secreting glands. There is lot of mucus forms. The mucus secreting glands of the respiratory epithelium make more mucus, which makes the breathing more difficult. And this viscid mucus become accumulated in the airway, and air passes, and the passage of the air become more difficult, which makes the breathing more hard. Next slide, please. Who is at the risk for getting COPD? The people, most of the risk are getting COPD who are the chronic smokers, chain smokers, or former smokers. After the many years of the smoking, as I told you, alpha-1 antitrypsin become reduced and have occupation that put more long-term contact the harmful chemical, dust, fumes, and other pollutants. The persons which are working in such areas, such factories, there is lot of fumes, lot of the airs, lot of the chemical dust which inhale with the air, and it came inside the lungs, and it causes destruction of the alveolar epithelial cells. Next slide, please. Beside these, some pollutants and allergens, they are also affect the lung. The person which lives in the area or building with the high level of air pollution, chemical fumes, asbestos, and other harmful dust particles. The persons which work in the coal factories, polluted areas, or some chemical factories, they also inhale these harmful particles. There is genetical condition which known as alpha-1 antitrypsin deficiency. As I told you, alpha-1 antitrypsin is more essential for elasticity and tunicity of these alveolar sacs and alveoli, wall of the alveoli cells. When there is alpha-1 antitrypsin deficient due to any congenital cause, because it is synthesized by the liver, and 1 out of 5,000 to 7,000 persons have this inherited defect, that is deficiency of the alpha-1 antitrypsin. It is the main cause of destruction of alveoli walls. Next slide, please. This is the major diseases of COPD: emphysema, chronic bronchitis, and asthma. One more disease, bronchiectasis, also included in the chronic obstructive pulmonary disease, but we discuss about these three diseases today. Next slide, please. Major diseases: chronic bronchitis, emphysema, and bronchial asthma. These two diseases, chronic bronchitis and emphysema, may overlap each other. Conditions such as bronchiectasis, extrinsic allergic alveolitis, and chronic airway obstruction also contribute to development of chronic obstructive pulmonary disease. Now, small airway disease involving inflammation of the small bronchi and bronchioles, bronchiolitis, and also included in the group of COPD. But these three major diseases, chronic bronchitis, emphysema, and asthma, We discuss today about these three diseases. Next slide, please. Chronic bronchitis. Chronic bronchitis is a condition in which defined clinically persistent cough with expectoration or most days or at least 3 months of a year for 2 or more consecutive years. It is a chronic condition in which there is patient complaints about the cough more than 3 months in a year, or these complaints may be continue with successive 2 years. Cough may be caused by the oversecretion of the mucus and overflow of the mucus. In spite of this name, chronic inflammation of the bronchi is not a prominent feature. So inflammation, diagnosed clinically, inflammation knows not a prominent feature, but the symptomatic diagnosis made in chronic bronchitis clinically, it is diagnosed with the patient complaints to the clinic with cough with more expectoration. The complaints are from 2 years or 3 years, and in a year, more than 2 or 3 months, 4 months, patient suffering from this cough and expectoration is considered or comes in the group of chronic bronchitis. Next slide, please. Causes etiopathogenesis. Main cause smoking. It impairs the changes make in the alveoli or alveolar cells by the smoking, that it impairs ciliary movement. The ciliary movement or the cilia, it gives a direction in the flow of mucus. If there is destruction of the cilia, the mucus plugging or mucus accumulation start. It inhibits the function of the alveolar macrophages. The alveolar macrophages will protect the lungs by the bacteria, viruses, or the microorganisms inhaled in the lungs. Macrophages fights with them and doesn't allow to affect the lung. But if there is history of chronic smoking, the alveolar macrophages action become inhibit or less in number. So the any infection which come to the lungs, like microorganism or which inhale by the any infected person, which attack the lung, and the protective macrophages action become reduced. It leads to the hypertrophy and hyperplasia of the mucus secreting glands. The mucus secreting glands of the respiratory epithelium become hypertrophied, and number of these glands also increase. They are overactive and releases much amount of the mucus. So excessive mucus secretion is the chief feature with the increase in the read index. So hypertrophy and hyperinflammation of this mucus glands causes more plugging of the mucus. It causes consideration obstruction of the small airways. The small airway or small bronchiole of the air tree become blocked with the much more viscid mucus. It stimulates the vagus stimulation and causes excessive bronchoconstriction. The major cause of this suffocation and dyspnea is the excessive mucus plugging or blocking of this alveoli with excessive bronchoconstriction. Next slide, please. Other causes are atmospheric pollution. If person live in a condition of atmospheric pollution under hygiene condition, and they have habit of smoking or any other dust or inhalation is there, so condition become more worse. If patient's occupation is like chemical factories, like daily he expose any fume, dust, or infection, or inhale this type of particle, coal, etc., the condition become more worse. If there is chronic infective condition, lungs are weak, or history of the ARDS, or some time of excessive dose of the infection of the bacteria, virus, or microorganism, they attack the lungs, the condition become more worse. Or if there is familiar or genetic factors, as I told you, like deficiency of alpha-1 antitrypsin, so these are also contribute the development of COPD. Next slide, please. Grossly, we see the bronchial wall become thickened, hyperemic, and more oedematous. Bronchi and bronchioles may contain much mucus plugs and purulent exudate. They doesn't in the free flow form. They make plugging or pool inside the bronchial epithelium. Sometimes they make the purulent exudate. So this viscid mucus along with the bronchial constriction make the condition more worse, or breathing become more difficult. Next slide, please. If we see microscopically, there is increased reed index. What is reed index? Reed index is the ratio between the thickness of the submucosal mucus plugs. It increased due to the excessive hypertrophy and hyperplasia. This mucous membrane become enlarged, thickened in the cartilage containing large air sacs to that of the total bronchial epithelial walls, and the bronchial epithelial may show the squamous metaplasia and dysplasia. With chronic effect of the smoking, we see the changes in the epithelium also. This squamous epithelium may show metaplasia and transform the other type, and sometimes with the chronic effect of this metaplasia, they change into the dysplastic change, and this dysplastic changes are the precondition or precursors of the carcinoma in situ. If there is history of the many years of the chronic smoking, carcinoma may be developed. Next slide, please. This is the diagrammatically we show the reed index. In first picture, we can see there is decrease in the total epithelium thickness due to less number of the mucosal cells. And second slide, we can see in second diagram, we can see there is number of the mucosal cells become increased, their thickness, their number increase, they release much amount of the mucus, and this thickness become increased, so reed index become increased. The total diameter become increased due to the hypertrophy and hyperplasia of this mucus secreting cells. Next slide, please. Clinical features of the chronic bronchitis. Persistent cough with the copious expectoration. This is the chief clinical feature of the chronic bronchitis. Sometimes we didn't found any pathological finding in the X-ray or other investigations, but patient clinically told the symptoms of persistent cough with the copious expectoration. Cough generally affect morning and night time. Morning catarrh is there. Patient wake up in the morning and clear his throat clearing, continues with the awaj of he is obliged to do this every day. Recurrent respiratory infection is there because of there is less alveolar activities, macrophage number become less, ciliary movement become less, so there is repeated respiratory infection is there. With persistence dyspnea, cough come at first and dyspnea later. Dyspnea comes after 6 to 7 months or after 1 year. With overlapping the cough symptoms, features of the right heart failure is there, and sometimes we X-ray shadow we can see the small heart. Next slide, please. Second disease is emphysema. There is some symptoms of the emphysema and chronic bronchitis overlap each other. Sometimes we confuse with the symptoms of emphysema and bronchitis, but chiefly chronic cough is the chief clinical feature of the chronic bronchitis, and dyspnea, it is more prominent in the emphysema. Next slide, please. Combination of permanent dilatation of the air spaces distal to the terminal bronchiole and the destruction of the wall with dilated air spaces. It means permanent dilatation which doesn't reversible, or this air space become dilated, excessive stretchable, and the condition comes when this air wall of the air spaces become broken or destructed with dilated air spaces. The air holding power, air holding capacity increased in the lungs. Lungs become over-inflamed. The emphysema is defined morphologically while the chronic bronchitis is defined clinically. This is a chief difference between the emphysema and chronic bronchitis. In emphysema, over-inflation of the lungs and lungs margin shadow become increased in the X-ray, and because of the enlarged lung, they compress the heart and we can see the small heart in this condition. Next slide, please. Etiological factors are more important: smoking and pollutants. They are the same in like other COPDs. Tobacco smoke, air pollution, they are the chiefly affect the lungs, and chronic exposure of this type of pollutants may causes destruction of the air sacs. The destruction of the alveolar wall is not linked to the bronchial changes, but it is closely related with the deficiency of the alpha-1 antitrypsin. It means alpha-1 antitrypsin may be contribute in development of the this alveolar sacs, because whenever there is over dilatation of the air spaces and congenital or maybe due to any acquired causes like chronic smoking. There is deficiency of the alpha-1 antitrypsin, which is protease inhibitor. It means it inhibits the proteases action. It means proteolytic action inhibited by the alpha-1 antitrypsin. Whenever there is deficient, the proteolytic action increase, and these protein fibers of the elastic walls of the alveolar sac become destroyed, and air space become dilated, and they hold the air. So graph of the expiration become low, there is difficult breathing, patient suffocate, and lungs become overinflamed. Next slide, please. Alveolar wall destruction in the emphysema by elastolytic action based on the imbalance between proteases, chiefly elastase, and antiproteases, chiefly anti-elastase. Elastase, which causes digestion of the elastic fibers of the alveolar sacs. By decrease this anti-elastic activity, that is deficiency of alpha-1 antitrypsin, by increased activity of elastases, that is increased neutrophilic infiltration in lung, causes excessive elaboration of the neutrophil elastase. Neutrophils, they are chiefly release this type of proteolytic action, and in this condition, number of the neutrophils increase, neutrophilia is there, and neutrophils releases more amount of the elastase, which contribute in the destruction of the alveolar walls. Next. We can see by this chart, smoking, which causes inhibition of the alpha-1 antitrypsin by the oxidant in the smoke, increase inflammatory cell recruitment. It means number of the macrophage or neutrophils increase in the numbers. So we can see there is ECM degradation, alpha-1 antitrypsin become reduced, and ultimately anti-proteases action become reduced and proteases become increases. So elastic damage is there and emphysema develop. It means chief cause is chronic smoking and deficiency of alpha-1 antitrypsin. Next. Grossly, we can see the lungs become voluminous and large, pale with little blood. The edges of the lung become rounded, not sharp. It is rounded. Advanced cases, we show the subpleural bully. Subpleural bully, it means there is, due to the increased accumulation of the air and stretchability of the alveolar, the peripheral pleura become, peripheral cells of the air cells dilated, and it pushes the pleura. So subpleural bully or ballooning may be seen, and small bleb formation, which is bulging outward the surface of the lungs. It means peripheral cells involved, and it dilated outside. So bully formation are formed by the rupture of the adjacent air cells, with blebs are the result of the rupture of the alveoli directly into the subpleural air spaces. It means sometimes peripheral alveoli directly rupture in the subpleural spaces, so it may be blebbed out like a balloon. So sometimes they become rupture and spontaneous pneumothorax may be developed. Next slide, please. Microscopically, you can see, depending upon the time of the emphysema, there is dilatation of the air spaces and destruction of the septal wall of part of echinus involved. That is respiratory bronchioles, alveolar ducts, alveolar sacs. Changes in the bronchitis may be present. Bully and blebs present, which show fibrosis and chronic inflammation of the wall. Sometimes we can see it in the healed lesion. The bully, which is rupture or chronic bully, may be healed by the calcification or any fibrosis, and sometimes the remaining cells which hold more amount of the air and make breathing difficult, and sometimes it depends the type of emphysema. Peripheral cells involved, central cells involved, or the echinus, which part of the echinus become involved according to morphologically. Next. This is diagrammatically we show the bullous emphysema. We can see the bully, peripheral or marginal pleural cell, alveoli cell become dilated in the subpleural spaces and make the bully. This is the weakest point of the lung. Due to the excessive stretchability, the bully may be rupture and spontaneous pneumothorax may be seen. Next. This is histologically. We can see under the microscope, this is broken spur of the septal wall and dilated air spaces, distended air spaces with thin septal wall. Whenever there is excessive stretchability, this septal wall become broken and we can see these broken spurs in the histological picture. Next slide, please. According to involvement of the echinus and which bronchial involve, morphologically it is divided. This is the normal echinus. If central portion involved, we call centric echinar emphysema. If terminal portion of echinus involved, we can pen echinar emphysema. Next. Difference between prominent bronchitis and prominent emphysema. As I told you, the symptoms of the bronchitis and emphysema sometimes overlap each other, and physician may be confused with the diagnosis. Sometimes both conditions may be present together. Difference between the prominent bronchitis and prominent emphysema. Generally, prominent bronchitis develop about the age of 50 years and prominent emphysema at the age of 60 years. Pathologically, there is pathological changes in hypertrophy of the excessive mucus producing cells, enlargement, hypertrophy, and hyperplasia of the mucus secreting gland, excessive mucus production. And chief pathological feature of the emphysema is destruction of the septal wall with narrowing of the bronchioles, inflammatory changes, and due to deficiency of alpha-1 dyspnea, it comes late and mild. Chief pathological feature is cough. And in emphysema, dyspnea is more prominent in the early and initial stages. In prominent bronchitis, cough is come before the dyspnea. Yani complaint starts with the cough. And prominent emphysema, it comes after the dyspnea. It means dyspnea comes first, then cough. Sputum, it is copious and purulent. In emphysema, it is scanty and mucoid. Bronchial infections is more common, we can see in the bronchitis, but infection causes are less common in the emphysema. Next. Respiratory insufficiency may be seen in chronic bronchitis terminal cases and in emphysema repeated cases. Cyanosis, generally we can see blue bloaters in the chronic bronchitis. Blue bloaters, it means the appearance of the patient becomes cyanotic due to the less amount of the oxygen, and patient appearance is bluish color, weak and bluish. Patient looks like blue bloaters, and pink puffers is the chief appearance of the emphysema due to the excessive dyspnea along with the hyperipnea on saturation of the oxygen, overinflation of the lungs. Patient seems pinkish color of the face, some stooping position, pink puffers is the appearance of emphysema. Lung capacity in bronchitis is normal and increased. It means lung become barrel shaped. We can see in the emphysema. So there is this some difference between for diagnosis of bronchitis and emphysema. Next, COPD, bronchial asthma. Bronchial asthma is very common disease among all respiratory diseases. Asthma is an episodic disease. Episodic means the patient otherwise lives normal, but when the complaint arises or attack of the asthma comes, patient condition become more worse. It's episodic disease or airway that is characterized by the increased responsiveness of the tracheobronchial tree to a variety of the stimuli. It means some kind of allergen, some kind of stimuli may affect the lung and make the lungs or tracheobronchial tree more sensitive. There is oversensitiveness, responsiveness of this tracheobronchial tree due to some variety of the stimuli. This stimuli or this variety may be a dietary factors due to any dust, due to any smell, due to any odor. They may affect and act as an allergen. Widespread spasmodic contraction. It means the whole bronchiole show the spasmodic contraction. It means excessive mucus production along with the spasmodic narrowing of the air passes. Air passes become more difficult, respiratory condition become more difficult, and the attack of the dyspnea comes. It may relieve spontaneously. Sometime this attack may be subside after the few minutes and patient become normal, and sometime it need any therapy, any inhaler or medication. Characterized by the paroxysms of the dyspnea, cough and wheezing. These are three main characteristic features of the bronchitis, chronic bronchial asthma, dyspnea, difficult breathing, cough, excessive production of the mucus and cough, and wheezing sound, that is whistling sound with bilateral bronchi. Next slide, please. Causes, extrinsic causes. There is two type of asthma, extrinsic and intrinsic. Extrinsic also called atopic and allergic asthma. Personal or family history is there, or allergic disease history may be there. If father or mother suffering from the asthma, grandfather, grandmother in the first relation, if there is history of the asthma, the son or next generation may be prone to get this type of infection. Intrinsic, idiosyncratic or non-atopic asthma. Later, an upper respiratory tract infection of the hypersensitivity of the drugs. It means in intrinsic asthma, there is a recurrent infection of the lungs or history of the ARDS, or sometimes laterogenic causes, excessive use of the drugs or medicines may be develop this type of idiosyncratic or atopic asthma. And third type of asthma is a mixed type of the features of both type of asthma. So number first, extrinsic asthma. Next slide, please. We can study this type of two asthma with differentiate features. Extrinsic asthma come at the early age, in childhood period, because there is history of the asthma in the parents. Intrinsic factor जो है, intrinsic asthma, it comes later in the adult age. Family history absent in the extrinsic asthma, commonly present in the intrinsic asthma. Allergic illness absent in the extrinsic asthma, but is present in the intrinsic asthma. Allergens like dust, pollens, they are present in the extrinsic asthma, but not present in the intrinsic asthma. Next. In the extrinsic asthma, there is involvement of immunoglobulin E is found in the serum. It is elevated in the serum. That is a chief cause. Or these are the triggers of the asthma which precipitate or triggers the attack of the asthma or attack of the dyspnea. We can see respiratory infections, allergens. Sometimes patient works in the pesticide or some perfume or other factories. It can precipitate the attack of asthma. Some temperature variations like changing of the weather, excessive cold, humidity, cloudy weather, rainy weather, the asthmatic attack may be precipitated. Sometimes there is violent exercise, running or exercise in the gym may precipitate the attack of asthma. Excessive cold weather, rainy weather, or sometimes cold blowing of the air, directly sleeping in front of AC may attack the asthma. Sometimes patient listen some bad news, came to the stress condition or emotional conditions, weeping condition may precipitate the attack of the asthma. Sometimes some medicines, capsules, steroids may precipitate the asthma. Sometimes tobacco, smoking may precipitate the asthma. Sometimes acidity, hyperreflex, gastric reflux may precipitate the asthma. Dust, foam, crops, food additives like beverages, eggs, potato may precipitate the attack of asthma. Petrol, smell, the fume, dust, pollutants, chemicals, it may act as an pollutants or irritants which trigger the attack of the asthma. There are some causes. Next slide, please. Three major pathological features we can see in the bronchial asthma: reversible bronchial constriction, bronchial mucus plugging, and excessive thickening of the bronchial wall. Reversible bronchial constriction may be seen due to the excessive fibrous bending outside the cartilages of respiratory walls. Bronchial mucus plugging due to the excessive secretion of the mucus from this mucus secreting glands, and bronchial wall thickening due to the hyperplasia and hypertrophy of these glands. Next slide, please. We can see in this type of pathological changes in the asthma, we can see this is normal bronchioles. We can see normal hollow pipe of this bronchiole, but in the asthmatic condition, there is very less space in this pipe, windpipe, and inflammation and hypertrophy of the hyperplasia of mucus secreting gland. In last picture, we can see there is excessive hypertrophy with excessive fibrous bending outside the bronchial epithelial cells, which makes the difficult breathing more difficult. Next. Grossly, we can see morphological features. The lungs are over-distended, over-inflamed. The cut surface show the characteristic occlusion of the bronchi and bronchioles with the excessive viscid mucus plugs. Microscopically, we can see. Next slide, please. Next slide, please. This is morphologically. Next. Gross changes. Next slide, please. Microscopically, we can see the mucus plugs contain normal or degenerated respiratory epithelium forming twisted strips called Kurzspan spirals. Kurzspan spirals are the twisted strips which detach from this bronchial epithelial walls, and with this type of spiral, Kurzspan spiral, we can see in the mucus of this respiratory epithelium. The sputum usually contain numerous eosinophilic and diamond-shaped crystals derived from the eosinophils called the charcot-laden crystals. This is also helps in the diagnosis of this asthma, which contain eosinophilic diamond-shaped white color crystals, which is called charcot-laden crystals. The bronchial wall shows a thickened bronchial epithelium, submucosal edema, and inflammation. Infiltrate the lymphocyte cells, prominent eosinophil cells. There is hypertrophy of submucosal glands as well as bronchial smooth cells. Microscopically, we can see in this type of inflammatory cells seen in bronchial mucus epithelium and mucosa. Next slide, please. This is the histologically diamond-shaped crystals, which is called charcot-laden crystals, and these twisted strips of the respiratory bronchial epithelium, which is called Kurzspan spirals. Next. This is charcot-laden crystals, mucosa, diamond-shaped crystals. Next. Kurzspan spirals. Next. Clinical features of the asthma. Asthmatic patients suffer from the episode of the acute attack with symptom-free period. It means patient is normal and otherwise normal, but when the attack comes, the condition becomes more worse. This attack of the dyspnea with rhonchi and cough and wheezing. There is whistling sound we can see in the lungs. Sometimes more bronchioles involved, the sound become more difficult, and clear whistling sound we can see as the air try to passes from this the hollow windpipe. This type of sound, whistling sound, we can clearly see from the patient. Sometimes we doesn't need any stethoscope to hear this sound. More attacks typically last for a few minutes to hours. Sometimes it is subside within the few minutes. Sometimes it lasts for hours. If there is prolonged attack of this type of asthma, there is severe respiratory spasm of the muscles. This condition become more severe, called status asthmaticus. This is a fatal condition. Sometimes this type of attack comes at the night, at the sleeping hours, and may cause death of the patient also. Next. Studies that may help in the diagnosis: physical examination, auscultation, sometimes investigation like X-ray, blood examination, spirometry, and arterial blood gases examination may help in the diagnosis of asthma. Because in the respiratory disease, these 5 or 6 features are the prominent features: cough, dyspnea, heaviness of chest, pain in the chest, and excessive mucus production and expectoration. And according to prominence of the features, according to this character of this expectoration and duration, we can find diagnosis of the disease. Next slide, please. Auscultation is very important feature. We can see symmetrical lungs or non-symmetrical lungs, over inflammation of the lungs. Sometimes in the case of dullness of the lungs, we can percussion is very helpful. Sometimes auscultation, like in the case of asthma, the bilateral rhonchi, monophonic sound, or this wheezing sound, very helpful to diagnosis of in asthma. which I see in the chest X-ray, excessive mucus production and white lobe of the lung help in the examination of this asthma. Blood examination, ESR level always rises with excessive eosinophilia in the allergic condition and neutrophilia in the atopic type of asthma. Spirometry, lung capacity become reduced, tidal volume become increased, lung become enlarged, and sometimes barrel-shaped lungs in the X-ray. Arterial gases, in the case of overinflation of the lungs or blue bloatus, emphysema, oxygen level become increased, and the case of bronchitis, hypersapnea is there, oxygen level reduced, carbon dioxide level become increases. Next slide, please. This is therapeutic or homeopathic medicines from the respiratory problems, chronic respiratory conditions, COPD. There is lot of medicines of this type of conditions, but I will discuss about some medicines. Brainia. In people, there is dry hawking cough with the rusty sputum. Sputum become blood stained. The homeopathic medicines, the symptoms are aggravated by any sort of the motion and the warm temperature. It means the temperature in the warm condition, patient become worse. And brainia generally is used in the condition of when the days are hot and nights are cold, like in the condition of changing of weather in early winters. Rheumax, the people with the dry stingy cough which is increased in the total temperature or by talking, the homeopathic medicines improves in this condition. Rheumax is very useful in the case of COPD, in the patient of chronic smokers or using the hookah or other tobacco. Next. Aconite, very important. If any acute attack of the dyspnea, it may subside by the aconite. The chronic remedy in the homeopathic remedy in useful in the condition acute bronchitis, acute emphysema, or acute attack of dyspnea. There are frequent sneezing, restlessness, coryza like symptoms with excessive perspiration. The patient worsen with the blowing of the air, cold air. In uniqueness of this prevent to development of the full-fledged bronchitis. In the condition of COPD, the condition become chronic, but attack are acute. If any medicines come into your mind, that is aconite. Kali bike, whereas patient has yellow, sticky mucus with worse in the morning, the homeopathic medicine is more effective. Patient mucus become thickened and sticky and condition become worse in the evening. The morning catarrh is there. Suffocation is there. Kali bike is the best medicine. Next. Next medicine. Other than aconite, belladonna is very useful. The homeopathic medicine useful in the patient with the bronchitis who have violent fever, distress cough, and worse lying down at the night. The coughing, spells the dry, short with the irregular breathing. There is also fullness of the chest with no pain. Through children might cry with the fullness. There is increased drowsiness where the patient sometimes goes off in a semi-conscious stage. In any condition where acute attack comes like fever, like pain, like chest pain, like heaviness of the chest, belladonna indicative and more effective. Sulfur, the homeopathic medicine is very useful in the people with the chronic bronchitis symptoms. There is a patient has significant rales sound due to the more air movement within the bronchi. We can patient self-observe the moving of the air in the bronchi. Condition is more worse aggravation at the morning. There is a accompanied with the mucus with the thickened and much may contain pus also. The patient could also suffer from the bout of suffocation. Next. Basilinum. It is also very useful in COPD. The homeopathic medicine used for the respiratory problems faced by the people who tend to catch a cold easily. They are sensitive, hypersensitive persons. Changing of the weather where the night are cold or some after the ride in bike or cycle, patient catches easily. The nose, face, this area is more sensitive. The mucous membrane highly irritated and patient feel very congested after exposing any cold air. There is a lot of homeopathic medicines like phosphorus, mercurius, entimtart, very useful in the asthma, Balletta orientalis, Rheumax, pulsatilla, ipecac, chelidonium. They also indicated and given to the patient according to the symptom similarity. But in the case of antimatode useful in the cellular asthma, in the patient works in the basement, and sometimes many medicines like pulsatilla may be given in the according to color of the sputum, sanguinaria, Rumex. They also useful in this COPD condition. Bromium, Drosera, they are also useful in chronic bronchitis according to symptom similarity. Always take the patient with the supervision of any homeopathic physician or consultant, and I advise the peoples never take the medicine by listening in the YouTube or reading any article, because physician take your whole picture and select a best medicine for you, and it will relieve your symptoms. So don't use self medications or reading the medicines in the internet. It may be dangerous or harmful. Homeopathic compound, the right compound determined by the multiple factors, including the stage, which is infection, at the time of presentation, nature of the cup, type of the mucus, aggravating or relief factors, presence a cold, overall health status, or the habits also. So management of the disease comes by leaving the smoking habits, tobacco habits, unhygienic conditions. If it is occupational, then we have to change the occupation or use the mask, leave the smoking, dust pollutants avoided, and sometimes this breathing exercises like Kapal Bhati, like Anulom Bilom, they are also useful. Change the lifestyle, and living in the overcrowded, unhygienic area avoided, or if there is changing in the weather, use mask or face mask or any hanky on the face. Avoid dust areas, crop areas. Allergic persons maybe take special precautions in the changing of the weather, rainy weather. If there is history of the asthma in the parents or in family, so they also take special precautions in these conditions. So this type of COPD, they are not curable completely, but with the help of medicine and with the best management, we can make the breathing and life more easy. So I advise to the persons, so avoid this type of such type of habits which affect your lung, weaken your lung, and make your respiration more difficult. So thank you very much. That's it about the COPD. If you have any questions, you can ask me. So thank you.
Thank you so much, sir. Thank you so much for the beautiful presentation. Participants, we are open for the questions.
I shared my PPT. If anyone want this PPT, he can
Yes,
take,
sir.
he or
Please.
she can take from ma'am. Okay, ma'am.
Yes, sir. Sure,
Because
sir.
I'm a pathologist, professor in pathology, I elaborate the pathological portion of this COPD along with the homeopathic therapeutic. Because we should know what kind of changes observed in the lungs in the case of COPD. Okay.
Definitely, sir.
Yes, ma'am. Okay, ma'am.
Sir,
So we are waiting for the question.
Okay.
Participant, please. We are open
If
for the
anyone have
question.
any question, he or she can ask me. No questions?
Sir, I would like to ask one question.
Yes, ma'am.
Regarding the experience, actually, I had one patient during the conversation and case taking. Actually, when I counsel regarding that he should stop smoking or he can manage that because of the wheezing. So the response which we get from the patient is like that he, if I can say it in Hindi, कि जब मैं स्मोक करता हूँ तो मैं उसको लंग्स में जाने नहीं देता हूँ, मैं स्मोक करके उसको नाक से ही निकालता हूँ.
But what is the age of patient?
It is 40.
40. And when he gets started this smoking habits?
Smoking habits, it's long back.
In which age?
Almost during 17.
17. It means almost 23 years. Years he used to smoke. Okay, ma'am.
Yes.
Actually, there is always some amount of the air goes to the lungs when we inhale the smoke. This is a myth theory by the smokers made that I never inhale the smoke in the lungs. He can smoke out by the nose, by the mouth, but some amount of the air always goes to the lung and damage your lungs. If there is history of the smoking since 23 years, so definitely lungs are weak and lungs are diseased. And after the history of 30 to 40 years, the lungs become weak and the breathing become more worse. So we can explain this to the patient to leave the habit of smoking and take the good medicines, and some respiratory exercises also there. They make helpful to these changes become reversible.
Thank you, sir. Thank you
Hanji.
so much. There is one question for the participant, that is, what is the utter need of inhaler when no remedy works in severe affections?
Ma'am, actually, inhaler, we never prescribe the inhaler. But if the use of inhaler make the patient easy to breathe, so in that condition, we can use the inhaler. Such seems the patient are asthmatic and patient face the attack of asthma. But in such conditions, if patient never doesn't use this inhaler, the patient maybe go to the worst condition or maybe fatal condition, or patient maybe die. So this pump or asthma make the breathe easier. It relax your respiratory muscles, accessory respiratory muscles, and give you time for your medications. Okay. If patient use inhaler, it means not a inhaler or any pump. It doesn't mean keep this disease is incurable. It give temporary relief to your respiratory muscles. So usage of the pumps or this type of inhaler is not a bad thing. In emergency, we can use this. Along with this, the medicines and medications proper diagnosed with the proper diagnosis and the habits and respiratory access is also necessary. Okay, ma'am.
Thank you, sir. Next question.
Yes, ma'am.
When Blata orientalis will be used in asthma? Like if you can put any light that when we can use Blata orientalis, some keywords or key points.
Blata orientalis, all of you know, it's made by the Indian cockroach, American cockroach. So it is helpful in the when asthmatic attack become precipitated. History of the bladder orientalis, you know, it is accidentally diagnosed when a cockroach fall down in the tea or water of prover, and he get relief by the asthmatic symptoms or asthmatic attack. So after this, we made this Blata orientalis mother tincture. This is mother tincture, very bad smell mother tincture, but it is very useful medicine. I also use this medicine in clinic in the attack of precipitation of asthma, and it gives much relief in the condition. It is a type of inhaler or pump. It acts like an inhaler or pump. The dose of asthma Blata orientalis gives instant relief to the patient. It is my personal experience. So it gives relief to the accessory muscles, respiratory accessory muscles, and make the breathing easier. But never use Blata orientalis repeatedly. It useful during the attack of or precipitation of the attack of asthma only.
Thank you, sir.
Yes.
I don't see any more questions from the participant.
Okay, ma'am.
Okay. So as I do not see any questions from the participant,
Okay,
thank you so much, sir. Thank
okay.
you,
Okay.
sir. This has been a very wonderful session. We have learned a lot regarding the pathology and microbiology, beautifully explained regarding the COPD, asthma, emphysema, and the differences regarding the diagnosis which you have presented. It actually clears a lot of doubts that when we see the patient, how we can diagnose it, and so that we can be having a beautiful hold on medicine so that we can guide through our homeopathic treatment. And thank you so much for sharing the medicines which will help in our acute and chronic episode for our patient. I'm very obliged to have you today, sir. Thank you so much. Thank you so much,
Thank you.
participants.
Thank you.
You're welcome.
Thank you all participants. Thank you.
Thank you, sir. Thank you so much for enlightening us with the wonderful session.
Yes, ma'am.
Respected participants, regarding the conference details and the I share links of the social media. It has been embedded in the chat box. So the all the details will be posted in that. So you can join hands with us. Thank you, sir. Thank you so much. Thank you, participants, for the wonderful session. And thank you all. Good night.
Thank you. Good night. Thank you.